as they come in, and we have leftover questions from this morning's dietary pattern session. And if I might, I'm going to ask my colleague, Dr. Nelson, to handle those questions.
Yes, sure. I'll give you a breather from your last session there. So I guess carrying off from some of the discussions we had this morning, one of the audience members was wondering, particularly for input from Melissa, considering how much we eat out, should we start pushing restaurants to reveal the percentage of fat or other ingredients on their menus? I know some cities maybe are doing it, but should it be more of a nationwide approach?
So there is a national law on calorie menu labeling that took effect in the last year or two for chain restaurants with 20 or more to provide calorie information at the point of purchase. So I know it may have been a while since some of us have eaten out in restaurants due to COVID, but that information should already be there for calorie information. And calories were chosen given that that's the most important information to have for weight management. So in order to add another nutrient to the information that exists, there would have to be another law passed by Congress. But right now, if you're eating out in chain restaurants with 20 or more, or other similar retailers like grocery stores that have prepared foods, you should already be seeing that information. And there also is a requirement that additional nutrition information be available upon request. So if you're looking for information about a specific nutrient, that information should be available if you ask for it.
Great, thank you. And along the same lines, we started a discussion a little bit in the morning, but you know, there are several different guidelines. You know, AICR have their guidelines. US has their USDA. So maybe you could comment a little bit again on navigating the similarities and differences between all these sets of guidelines, and other people on the panel can definitely chime in on how you incorporate that into your practice.
Yeah, and as I had said in the prior session, I think that the dietary guidelines and AICR's guidelines are more similar than different. And I think that that would be the case for other evidence-based dietary guidelines focused on chronic disease prevention, such as those from the American Heart Association or the American Diabetes Association. Certainly AICR's are more focused on cancer, and so therefore some of the recommendations are specific to cancer prevention that are not included in the dietary guidelines, which are focused on overall health. I will note that the advisory committee's report that was developed by a committee of independent experts put out a series of conclusions and recommendations that were very consistent with AICR's evidence. And so the only place where you do see the difference is in the translation of that evidence in the development of the actual policy document of the dietary guidelines. And so, you know, we don't know exactly what went into that thinking, but certainly in the review of the evidence by the advisory committee, their conclusions were very similar to those reached by AICR.
Great. Does anyone else want to weigh in on that? All right. Thank you. Moving on then. This question will start directing towards Ed. So you alluded to in your discussion that there may be some synergy between different dietary approaches, in particular for cardiovascular disease, but I think also for cancer. So could you maybe talk a little bit about the concept of dose or the concept of combinations, and how we as researchers can start getting at that to provide people with strategies and guidelines for what, not just, you know, how much fat to eat, but what types of fat, or how we can combine these things?
Yeah, I mean, I think it's a great question. I'm not sure I'll address exactly what the person is looking for, but I think some of the guidelines are pretty broad, like fruits and vegetables. And it depends, like what do you count as vegetables? You count like potatoes, French fries. And now, like for some things, and I'm speculating a bit here, but let's say like for blood pressure, it may be primarily the things like potassium, magnesium, sodium that are important. And for that, like overall fruits and vegetables might be a good marker, a good indicator. If there are very specific compounds for cancers that may be important, then the broad recommendations won't be good. So like, just as an example, like there's some evidence that lycopene is specifically protective for prostate cancer, but that's in only a very few select, fruits and vegetables, primarily tomatoes. So broad recommendations like 5 a day, you can meet the 5 a day and eat no tomatoes. So I think we do need a lot more refinement in terms of the types of foods. In terms of like, as you mentioned, like the types of fats, I think types of fats are particularly important for cardiovascular disease. They may be important for cancer, but I think quantitatively, probably the biggest impact will be on heart disease, because we already know they're pretty strong effects. And sometimes there might even be like conflicting things, like I don't think this hypothesis has stood out over time, at least in my opinion, but there was some indication for the polyunsaturated fats might be bad for cancer, which they're probably very likely to be good for cardiovascular disease. So I think I think the broad guidelines are generally good, and I think for most people they're good, but I think there's so many like specifics in terms of the specific types of foods or fruits and vegetables, types of fats, types of protein sources that really need to be teased out, and they could be different for cancer, cardiovascular, diabetes, other conditions. There's a lot of overlap, I'm sure, but I think there may be specific differences for different diseases.
Great. I'm going to flip the questions to our exercise experts now. And similar question, how do we come up with exercise dose or regimen? And I know some of the previous talks talked about resistance training versus aerobic. Do we have good enough evidence to suggest one is better than the other, or how do you approach that in your clinic in terms of?
Right, I'm jumping in on that one. The answer to your question is for what? Exercise really is and should be dosed like a medicine, and we don't tell people to go get some chemotherapy. We don't tell them to, go get some radiation. We tell them that we're going to give them doxorubicin at a certain dose according to their body surface area every 3 weeks for 4 rounds, right? So we need to be dosing medicine, exercise like a medicine. There are people on this panel who are doing work very much in the space of precision exercise oncology. And so the idea is, we need to be prescribing exercise for specific outcomes. If we're talking about cancer as an outcome, the primary prevention of cancer, or if we're talking about prevention of recurrence or prevention of mortality, frankly, the data are much more scant. It's very much in the realm of epidemiology, and there are some very, very large trials that are ongoing. They're not complete at this time. But there are a number of intermediate markers that I think are under study at this time. And, Neil, I wonder if you want to speak to this. And I think that there are a number of what the ACSM roundtable called cancer health-related outcomes, which are all the symptoms and side effects that, may have an effect on treatment tolerance and may not, but certainly have an effect on quality of life, that we do have the ability to give what we call a fit prescription, which is frequency, intensity, and time, for a very particular outcome, for fatigue, for anxiety, depression, et cetera. So I'll toss it to Neil.
Thanks, Katie. I couldn't agree more. I think that in addition to the important points that you raised when it comes to dosing, we we need to, and we are, we as in people on this panel and our colleagues out there as well that are studying exercise and other lifestyle interventions, need to also evaluate the intervention as we do medications. And so, for example, not only dosing or applying a dosing schema to exercise or lifestyle interventions, even nutrition, but evaluating adherence in terms of relative dose intensity, dose modifications, the same kinds of measures that we would use in a drug trial to bring a drug to approval. That's the same kind of paradigm that we're working on with exercise. And I think that's going to be important because, as Katie pointed out, the outcome of interest is going to really dictate the way in which both the setting and the dose that we use, I think, for a lot of these interventions. I also wanted to dovetail on a point that Ed made in terms of some of these macro and micronutrient components of dietary interventions. I think that's going to be an exceedingly important area to look at precision medicine in terms of dietary recommendations for patients dealing with cancer. So, for example, we know that tumor biology is directly relevant to the metabolism of macronutrients and the ways in which tumors use those macro and micronutrients. And can we modify that specific to the tumor phenotype and thereby modify the dietary recommendation that we're making? So I think all of this is very important for dosing, but also matching the intervention to the phenotype of interest.
So very related. So anyone can take this question, I suppose, but in this regard, are we considering differences in ethnicity, race, age of patient, this sort of thing?
Yes.
Yes. Yeah. I mean, I'm not the expert on this, but I can just say one thing that is something that we're very interested in, and I know others have done a lot of work on this. You know, we know that that cancer phenotype and tumor biology does vary by age, ethnicity, race. We also know that lifestyle patterns vary by all of the above. We also know that host factors, microbiome, metabolic factors, inflammation, et cetera.
Maybe I should preface my question by, you know, when I read the guidelines, say, on what I should be eating or how much I should be exercising, it's just like everyone should be exercising 3 times a week, period. And everyone should have this many calories, this amount of fat, period. So are there efforts underway? And so I guess, yes, I think we all realize that everyone's different, everyone's individual, but how are we, in terms of forming guidelines, how are we going about starting to make them a little bit more specific to different people? And now no one wants to take my question.
You know, I think that there are, you know, some people that are in the area of, so are you like hearkening to maybe precision medicine, precision, you know, so diet and exercise within the realm of precision medicine. And I think before, the general public, I think, has a much different notion of how advanced we are in regard to that, which is not advanced at all. We know very little. There's so much more research that needs to be done that I think that is the holy grail, Eric. But I don't think we're there yet. And I would really welcome other opinions on this. Chickens.
I agree. This is why I'm throwing it out there, starting the conversation. All right, I'm just going through our questions. Catherine, feel free to jump in if you've got a question ready. So one person is saying, what efforts does the AICR have involved or trying to impact food nutrition policy in order to gain insurance reimbursement to cancer survivors or to obtain cancer prevention, nutrition, education, or guidance. So maybe this is a question for Melissa.
Sure, I'd be happy to take that. So there is a piece of legislation that was introduced in the last Congress that AICR endorsed called the Medical Nutrition Therapy Act. And that bill would require Medicare to provide insurance coverage for medical nutrition therapy, a type of nutrition counseling for people with chronic conditions, and people with cancer would be included in that. So AICR endorsed the bill during the last Congress. We expect that it will be introduced again during this Congress. Certainly passing legislation takes a long time. So this is going to be a multi-year process to move it through the legislative process and then hopefully in the regulatory process to get it implemented. But this is definitely something that AICR is interested in and supportive of and looking forward to continuing to advocate for.
All right, thank you. Going down the list of questions then, maybe a question for Ed. What biomarkers are sort of the top of your list? What should we pay attention to when we're looking for the effects of lifestyle, either physical activity or diet on different interventions?
Yeah, and I assume that the question is for cancer. I mean, some of the I guess I would call them low-hanging fruit are things like where there's more evidence that they're linked, the biomarkers are linked to cancer risk, are things like, insulin-like growth factor, IGF, insulin, probably some of the inflammatory markers. I mean, I think those are the ones that like my group is focused on. I'm sure there are others and other people can chime in. But I mean, I think first the data has to link the biomarker to cancer outcome. Another one, is like estrogen for breast cancer, obviously. So I mean, I think those are the ones we probably should start with, and they probably will differ for different cancers. Like for prevention, you probably want the biggest impact. I think that the thing about some of the ones that I mentioned, the markers that I mentioned, they do seem to hit more than one cancer. They're like, for example, the insulin inflammation may be relevant for a lot of the obesity-related cancers. And there are about 12 or 13 cancers related to obesity. So for primary prevention, you want something to have a really big impact. We sometimes talk about cancer like it's one disease, but obviously it's not. And there are different factors that may be relevant for specific cancers and even subtypes within the cancer. And I think with the more evidence coming out from metabolomics and other approaches, we may have more biomarkers to look at. But I think, I don't know if anybody off the top of the head, but those are the ones that come to my mind. But that's my bias because that's what we've been focusing on.
Right. So I agree with you, Ed. And obviously it's what people have looked at, what there's been plenty of papers on, what are certainly people add to their grants. I would actually argue we just really don't have good biomarkers. And that's been some of the biggest problem, is to try to find intermediate endpoints, right? So looking for cancer prevention, you're looking at something that's going to take years to decades, even for cancer survivors, to look if it's affecting recurrence or their survival. And unfortunately, most of them have not held up as much as we'd like to really think that they're an intermediate endpoint. I still think they're important, and we think that's probably some of the mechanism of some of these factors, but they really haven't been helpful as intermediate endpoints, and that's been a lot of the challenge in sort of knowing how to move forward with certain recommendations.
Yeah, no, I agree with Jeff. I think one of the things to bear in mind is, and I even have like a slide that shows this, like a lot of these biomarkers, especially what we call obesity related biomarkers, they're all interrelated. If you whatever, like let's say if you exercise or lose weight, okay, your insulin will go down. Also, a lot of your IGF binding proteins will go up, leptin will go down, adiponectin will go up. They're all interrelated. So it's going to be really hard to tease out like which is the biomarker. There is some evidence from Mendelian randomization that, for example, that actually like for I think kidney cancer and uterine cancer, that the insulin does seem to be like, quote, the causal factor. But I think they can, like the biomarker can still be useful for like interventions. And so for example, I would argue that an intervention that, let's say, reduces C-peptide or insulin levels will probably have an effect on the cancers that are related to those, even if at the really mechanistic level, it's not directly mediated by insulin. It may be the IGF binding proteins that may be the more causally proximal factors. But it's going to be so long for us to really find out the mechanistic level, what's exactly going on at the cellular level. So I think we have to start somewhere. And I think the biomarkers, I think of them more as useful intermediates of processes related to cancers, but they may not actually be the causal factor at the molecular level.
I just wanted to add to that, at the clinical level, I think what we also need to utilize some of these biomarkers are data from intervention trials in terms of effect sizes and relationship of those effect sizes to outcomes. If I measure someone's CRP or insulin level in clinic, we can tell them what that means for their diabetes risk or what that means for their cardiovascular risk. We don't yet know what that means for their cancer recurrence risk. And if we do measure it, how low do we go? If they're exercising and they drive it down, do we keep going? To what degree of an effect are we going to have on their cancer recurrence outcome? And I think that data we can get from intervention trials, and that's data that we need.
Yes, I agree. I think there's a lot of work to be done in biomarker development still. So let's switch gears a little bit again. And this morning, in this morning session, we talked about sort of coming up with guidelines. And Dr. Slidis, he mentioned that, quote, the assessment of evidence is intrinsically subjective, which maybe is a bold statement, but we often use frameworks to come up with our guidelines that could appear anyways fairly rigid. So I guess I'm asking the panel to weigh in and comment on what their thoughts are of the relative roles of framework versus expert opinions or consensus statements. So I open the floor. And if nobody understands what I'm, go ahead.
I can make a comment from a pediatric perspective, which we often are deferring to expert opinion because our evidence is limited and we have a signal that's very strong about an adverse effect linked to an exposure. And I think, from an AICR's perspective, you may have signals that would make common sense that these are behaviors that we need to be addressing, but you don't have the evidence that say, how can we begin those discussions and implement whatever intervention that we think is going to improve health. So the stance that pediatric oncologists have taken in their guideline approaches, as we are helping, our evidence is emerging for so many of outcomes, is to still acknowledge that expert opinion has its place, but address what those research agenda items are and pursue the research. So I think there is a place for it because we're in a world where it's difficult to implement some of these clinical trials to get the high quality evidence that one needs, and we need to care for patients at this point.
I'm gonna go ahead.
I was just going to add, from a policy perspective, I think we want our policies to be as evidence-based as possible, but where there are gaps in evidence, we also don't want to wait to implement policies that will support individuals in making healthy choices that move in the right direction. So while we certainly want policies to be based on the best information available, if we don't know exactly all of the details about everything, I think we would want to move forward using the best available evidence and filling in the gaps with expert opinion, but certainly then following up and evaluating the impact of policies and using that to develop a future research agenda so that we can continue to refine policies and interventions and grow the evidence base to have even stronger policies and interventions going forward.
And one thing that we've done as the evidence is not available, and recognizing that the lack of evidence is not absence of evidence, is that we are increasingly in some of these topics using shared decision-making, helping the patient understand, benefits and risks and harms. And of course, I'm talking from a surveillance, not particularly behavioral, but we introduce these behavioral concepts too. So I think there's still a discussion that you can have with the patient that addresses this in a shared decision-making capacity when the evidence is lacking.
I think this is an interesting place where implementation science, precision, nutrition and exercise, oncology, policy and decision-making come together in a really interesting place with this question, Eric. I think, Wendy made a comment earlier about, that there are some who believe that that some of the policy statements that have been made about nutrition didn't go far enough, were not specific enough. And, we certainly, with the ACSM guidelines that came out in 2019, we were exceedingly eager to be really, really precise about, for fatigue, this is what you need to do during chemotherapy. And that eases implementation. It's easier. It's not just go chemotherapy. It's go walk 3 times a week, 30 minutes. This is your, intensity. This is what you need to do for this outcome. So, so I think that there's an interesting sort of focusing of the lens that I think could happen as the evidence matures for both nutrition and physical activity. And I'm curious to see if Wendy has anything to say here.
Let me unmute myself. I think that's an important, concept to hold in our palm as we're going forward with public policy. But then I also want to hearken to one of the comments that one of the participants made, and that is, from the standpoint of the common person, the average American that's out there that's trying to make sense of all these guidelines together. And when they do, and I appreciate the fact, Melissa, that you pointed to, yes, most of our guidelines are consistent and they align with one another. But there are some key areas where they don't. And of course, that's, this is just like a magnet, right? This is where people go. They see the discrepancy and they're trying in their brain to decide, okay, well, why is there a discrepancy here? And, and if so, why? And I think we do a disservice if we put out guidelines that aren't consistent, right? It does confuse the American public. They don't know what to follow. And that's something that we see in our patients. They say, I really was interested for a while, but then I threw up my hands because there's just so much differing opinions out there. And, for them trying to sort, pick their way through, I think as scientists, we can say, yeah, well, that study didn't control for this, and that's why you got a different result and that sort of thing. And we can reconcile that. But we also have a responsibility, I think, to the public to have guidelines that are consistent. And coming back to one of the points that Melissa made is that, and you made it too, Katie, in the absence of information, and if we know there's no downside, why do we hold back? And so I don't know, I'm always conflicted when I'm on guidelines panels and, you know, we're pushing, we see some evidence there, you know, and all in all, the message seems good, but then there's part of us that's that then lets up and says, ooh, what are we doing? We're telling people to eat apples. Oh my God, what's going to happen to them if they, you know, if they eat apples? And it's, you know, I know that when we amassed to do the ASCO guidelines for dietary guidelines, you know, Cindy Thompson said, oh, heaven forbid that we tell people to eat apples. That would really be a terrible thing, being very facetious. So somehow we have to come to grips with the fact that there's going to be some things that we're going to recommend that really don't have a downside. Yeah, we can't promise good health with it, but what's the downside? I don't know. I'm opening the floor for people that want to chime in.
So Eric, can I throw a question in here that I think is appropriate, a follow-up? And that is, the question is, you know, we in our session on physical activity, there was discussion of cost. And, you know, so I think it's an appropriate thing to bring up in light of what you just said, Wendy. And so the question coming from Kathy Lehman was, why not have survivors pay for some portion of any programs? And I think her intent was to ask about physical activity programs, but could well be that she would talk about a, you know, consultation with a nutritionist as well. There seems to be a mindset that cancer survivorship programs must be offered free to participants. And so there's curiosity about whether paying for a portion would impact adherence or consistency. Have any of you played with that, asked people to pay a little fee? How has it gone? Do you know of any evidence in this area? I want to know too.
You know, the evidence that you're suggesting is a lot in the weight loss literature. So that for weight loss programs, if individuals actually pony up some money, they tend to have better adherence. Now, can we generalize that to the cancer population? I don't think so. And I'm cautious, because here's a population that suffers from the financial toxicity. They're just reeling from treatment. And now you're going to ask them to pay for something else? I'd be hesitant.
I think that also raises some equity issues. I think there will be a certain portion of the patient population that may be willing and able to pay for dietitian services or a physical activity program, for example, but there is a large portion of the population that where that would be a significant barrier. And as Dr. DeMark-Wanifried mentioned, this is a patient population that's already has suffered from financial toxicity and has borne a huge cost for the large majority of the patient population of the costs of their treatment. And so I think it's certainly an area worth further research, but I would think we would want to be careful about considering what the equity implications would be of that as well.
Yeah, I don't disagree at all. I totally agree. And, but some of this also, and some of it is learning how effective. I mean, we've all learned over the past year that we can do a lot of content and teaching, et cetera, just the way we're doing this right now. And so you can imagine different levels of content to help people achieve these different goals. So for some people, whether you could make available free exercise classes or sessions or strategies virtually, and then some people will have different means to be able to join a gym or have a personal trainer, et cetera. And as long as there's sort of options for different people, depending on what their preference is, and also what, to some degree, what they can afford. But we do probably need to learn for sure that each of them could have some benefit, depending on the strategy you use.
I do want to say there are some cancer centers, which will remain nameless, I'm not going to say it, but that are really making a pretty penny off of cancer survivors, right? You know, offering boutique programs and really, you know, cashing in. There are some of those that have published their results. And yeah, they look darn good, but I'm a little bit hesitant to look at those data and say, well, we could expect that from, you know, most cancer survivors.
So Wendy, what is it going to take to make nutrition and exercise standard of care at the University of Alabama?
Oh, that's a good question. And I am going to ask my colleague, Laura Rogers, who's probably even more adept at being able to answer that. But, you know, as a cancer researcher, and I've been at multiple institutions, which will remain nameless through my academic career. And the beauty of them is that I can always do a research program and not have to worry about my control condition, because there is an absence, a complete absence of services for people. And that's a shame. But I don't know how to answer your question. And so I'm a chicken. I'm going to turn it over to Laura.
All right, Laura.
Now I'm speaking generally here. I think there are two main ways that it can be integrated. One is if you have philanthropic funds. So in other words, some cancer centers have big donors who set up survivorship programs, oftentimes specific to a cancer type, but those can cover some of these supportive services that are not typically covered by insurance. I think as far as if you, for example, hearing about this bill related to Medicare and medical nutrition therapy has me doing a little dance under the desk here, because you know, that's how we're going to pay for the dietitian time, you know, with the cancer survivor. And that's worked really well in our weight loss medicine clinic. Is as coverage for medical nutrition therapy has expanded, we've been able to give access to the dietitian more readily to the weight loss patients. But the exercise access, so I can just speak from my own personal experience. If you don't have the philanthropic funds, you have to be very creative about how you bring it to the health system, and you have to show a value added. You almost have to show the value added before they'll actually give you any money to do it. So you almost have to do it first without their money, and then they might pay for it long term. I'm currently taking the strategy where I think about exercise as a spectrum that goes from PM&R, physical therapy, you know, cancer, clinical exercise physiologists, community programs, self-management. It's a little spectrum. And so I'm collaborating with the PM&R group to sort of start at that end of the spectrum and try to build it out across the spectrum until we eventually get to the fully self-management end of the spectrum. But all of that is just so we can try to work within the health system value and limitations. It's not an easy answer, but certainly good to have the conversation.
And it's not a straight line. Laura shared a slide with me from the implementation science group that showed, if you can just imagine, you know, there's what you think it's going to be with implementation is this straight line. And the truth is this crazy, you know, peaks and valleys and you know, non-linear route from one side of the slide to the other. So anybody else have any other comments about implementation?
I'm just going to echo some points that our audience participants have made, and really this is highlighting something that's not new to us, but that there's disparity in all walks of life, particularly in cancer treatment, and those getting cancer treatment, it often creates a financial toxicity, if you will. And we're now discussing some sort of a step before then, nutrition and lifestyle also being a disparity and disparate access to various places, or even disparate access to grocery stores that have nutritious foods. So that several audience members have sort of chimed in on that, and we're wondering if we could comment on any of that, or obviously this is not a short or easy solution, but are there any strategies we have to kind of minimize these disparities?
I'll just say, I think we know from the financial toxicity literature that recognizing the risk factors and intervening early has shown signs of early success in terms of at least mitigating some of the financial toxicity that's attributed to cancer treatment. I think extending that kind of approach, not just to what we traditionally think of as cancer treatment, chemotherapy, visits with the doctor, but to everything that cancer therapy encompasses, including what it should encompass, nutrition, exercise, and so forth, and evaluating for the potential disparities right at the beginning, or difficulties accessing some of those resources right at the beginning, and trying to address that early on might be an approach that mirrors some of the success that has been seen in financial toxicity for cancer treatment.
Also, just to add with respect to increasing implementation of and incorporation within the healthcare system of nutrition and physical activity programs for cancer survivors, I think we need more research on how they contribute to overall improved outcomes as well as improved costs. I think that's the way that you're going to get payers to want to pay for these. And I think you need to look at bundled payment models and the way that the future of the healthcare system is moving. And I'm not sure that we're going to be successful in necessarily getting every payer to pay for physical activity or oncology dietitian interventions as a fee-for-service in a fee-for-service model. But if we can demonstrate through research how providing patients with these interventions improves their overall outcomes and reduces their costs, then I think that a payer is going to be interested in that type of research and may be more willing to incorporate those services into their payment model.
I would like it very much if you would review my R01, please.
I also wanted to jump in because I feel like I have to jump in and kind of say something about the value of implementation research within this context. I think is really, really, hitting on a couple of points that the panelists have made before. This is one of the ways that you could really think about health equity within this space as well in reaching underserved populations and understanding from the very beginning and not at the end of the development of the intervention. How do we cater to the needs, the specific needs of these populations from the start of the design, if not at the start of the design, at least during the design, during the implementation. So that focus on implementation is going to help address some of this issues of sustainment, of thinking about equity, but also thinking about, how are we incorporating the setting level characteristics, cost being one of them. I also wanted to tie in, Dr. Hudson had mentioned shared decision making in terms of, opportunities where there is a lack of evidence yet. One of my favorite quotes is from Dr. Ross Brownson: "Evidence lies in the in the eyes of the beholder," right? So it is catering to these multiple stakeholders, multiple opportunities and influences on how evidence gets used, utilized, and implemented in our real world practice. So just a quick plug-in for implementation research as we are thinking about evidence and creating evidence and disseminating and implementing evidence. How can we bring in some of these scientific methods and principles to help address these questions for real world practice?
And I just want to make a comment that flags on to what Prajakta said is, as researchers, we also have to be very open and very cognizant of interventions that are really simple, or not, maybe not really simple, but that have really good dissemination potential and not make them so complex and so costly. So how can we deliver the most cost-effective ways to reach people with good information and roll it out there so that they really can partake? So, you know, I think a lot of it is on our shoulders as researchers, as well as practitioners, to find the way that we can really increase the efficiencies and the impact of our programs.
To pick up on
Absolutely.
Dr.
There's a reason why soccer is such a popular sport, because all it takes is a can and people with a couple of feet. So for sure. Go ahead, Melissa.
I was just going to pick up on Dr. Edsel and Dr. DeMark Wanafried's points. And I think it's important to think about where people get their information. So most people in the general public aren't reading guidelines. They're reading news stories, they're reading social media, they're talking to their friends, maybe hopefully they're listening to their clinicians. And so when we think about all of the various sources of information that are out there, a lot of the information is not evidence-based, and it's a lot of it's opinion, and it's saying a lot of different things. And so I do think it's incumbent upon those who are researchers and experts and those who understand how to analyze the evidence to elevate the information that is evidence-based. And to be clear, for example, when a new study comes out that conflicts something said in a prior study, that doesn't mean that we know nothing about the topic. That means that additional research is building on and refining our understanding of an issue. And so I think it's a lot about how the information is framed in the popular media and in social media, and more broadly with the general population. And so I think we need to think about not just how is the information communicated in the guidelines, but also how can we translate that in a better way for the general public that makes it easy for them to take action. They don't just throw up their hands and say, okay, well, this study contradicts what was said before, so I guess we don't know anything, so I'll just do what's easiest and most convenient for me.
All right. I'll just bring in a little bit of what the audience have said too. There are evidently a lot of places that offer some free exercise classes or yoga classes. Evidently, at least from this person's experience, they're not all that well attended, but as we increase our outreach into the community, it's maybe we're behooved to check those out and maybe recommend them. There's a sort of an interesting question here that I open to the entire panel. Sort of, what are your thoughts on prehab or prehabilitation prior to other interventions? And in the same line, how do you figure out which patients should go into prehab? Do you base it purely on body mass index, or are there other metrics you can use to determine sort of overall lifestyle and whether they should go into prehab?
So actually, I want to address your first comment, and then happy to let folks talk about prehab. There was actually another comment in the audience comments as well about people maybe not being willing to come back to what I call the mothership. You know, maybe not being willing to come back to the place where they received what might be considered by some a trauma of the diagnosis and treatment of cancer. And so there is some thinking towards, you know, maybe having on-site yoga and Tai Chi classes isn't the right way to go. And this is where, you know, COVID has given us the gift of, as people have mentioned, of figuring out that we can do more things at distance. And, you know, so I think that it's not surprising to hear that on-site classes are not particularly well attended by some folks. I think that's probably the finding in a lot of centers. And that then is used as excuse for, oh, well, nobody wants the program, which is not the right instinct. I think it's, you know, it's an implementation problem. So, okay, now prehab. You asked an excellent question about prehab. How do people decide on prehab? I'll let others take that. Or not.
Yeah, apparently it's a really new concept. Obviously, we do this in other standard of care, right? Particularly in Europe, before surgery, you go on adjuvant or neoadjuvant chemotherapy.
Yeah, I think there's a growing evidence base in colorectal cancer, and I recently did a review on the upper GI cancers, and there's sort of emerging there. I think we're really very, very much still in the let's build the evidence base phase of this storyline. Laura, did you have something to add?
No, I agree with you. That was pretty much what I was going to say. The little evidence that we have shows benefit with prehab. As far as selecting who gets it, when you get it, how much you get it, I don't think we don't know.
Got it. Well, there are plenty of other questions, but maybe I'll open up the panel, and if there's anything burning that you want to speak to the world about, related, obviously, now's your chance.
I have a question. I mean, I have a comment related to the lack of attendance at the exercise classes. From a health behavior standpoint, or perhaps as a public health standpoint, a really important question that I don't think we know the answer to is how to get the people who are not interested, who you can't reach because you don't know who they are and they're not coming to you. Somehow you want to give them messaging so they will become interested enough to be willing to participate in the activities. So that the engaging of the cancer survivor, especially those who are not interested, is really important. I also want to reiterate that a single message, as much as possible, a simple public health message, I think is really critical, because especially, I mean, if you think about disparities and the differences in health literacy and difference in education and how people are going to interpret the information, it's just really important. I guess I spent a lot of time talking to people who know who knows very little about diet or exercise to start with. You can't even begin you have to begin at very early in the knowledge base of those topics with people, and you really can't get beyond 150 minutes a week. If you can get them to do 150 minutes a week of something, you've really made progress. So sorry, that was my burning comment.
Yeah, no, that's excellent. I'd just like to, well, first of all, to engage those that may have lost, I will promote the use of advocates in everyone's research, from basic through clinical, as well as if you're a practitioner, the use of advocates is great. And then I'm going to wrap the panel up. And before people log off, though, Deirdre from the AICR would like to say a few general comments.
Thank you very much, Dr. Nelson. Really, I'm just saying thank you to everyone who had a hand in planning this, the chairs, the program committee, all of the speakers. It's been a fantastic discussion. And what really struck me was some of the breadth of the discussion and the level of detail that we were able to get into. But also, given that this is a virtual event, it felt very intimate, seeing you all on screen and having this interchange of discussion. And I think that's actually quite a feat to achieve for a symposium like this. So I congratulate you all. And I think that definitely served us well in terms of this really being a high level discussion that you were all passionate about. And I'm addressing not only the people I'm looking at on the screen, but all the other speakers who participated today. We really do thank you. It's been fabulous, and I can't wait for November when we're able to take more time discussing these topics and many, many others. Clearly, there's a lot of work going on, and there's a lot of work to do. For our part, we are passionate in trying to get the research that you do into the hands and minds and hearts of communities and of individuals. And we try very hard to do that. As Melissa said, there are a lot of obstacles, the media and being just one. We will continue to do our part and continue to partner with you on that endeavor. We know it's critical, and we think we're getting better at it, but you know, it's a huge challenge, but it's something we can overcome if we take it a bite size at a time. I'm very heartened to hear all about the implementation science. I think that's terrific in helping us drive our work forward. But of course, our work is founded on the basic and epidemiology science too, so it all works together. So with that said,
can I just interject?
Yes, absolutely, Wendy.
I just want to say it's wonderful that you've launched your Healthy 10 campaign. And that is just, that's a fantastic resource. So, you know, here we are kind of belly aching about that there's a lack of resources in the community, but the AICR really does help our patients a lot. So, and
Thank you.
I want to just tell you that.
Thank you, Wendy. So Wendy's actually referring, I'm sure you're all aware, February is Cancer Prevention Month, and we always do a big campaign. And our campaign this, I love that, Ed, this year is Take the 10, and it is built around Take the 10 Healthy Challenge, which some of you may remember we had the New American Plate Challenge, and we've revamped it into Take the 10 Challenge, and it reflects the 10 recommendations, as well as all the other work that you're doing. So it's nutrition, it's trying to get the portion size right, and it's being physically active. And it's deliberately, hopefully, you know, we know it's not simple to do things, but they're relatively simple steps to try and get people moving the right way. So we're sharing it widely throughout February, so I encourage you to do the same. Thank you, Wendy, I appreciate that. So I think we're ready to close. We're right on 3:30. I love this. We opened at 11, we're closing on time. Thank you all very, very much. Look forward to seeing you in the future.
Bye.